So, having seen about the controversies surrounding the diagnosis of GDM, now we will move on to this third module on management of GDM. So, the management of GDM, we have two broader aspects. One is the therapeutic options, which we have seen patch and patch in the other modules. And the second part of it will look into the obstetric management also, the little bit that we need to know as a physician or as the diabetologist who are going to handle this patient. So, the therapeutic options, when it comes, the first thing that we need to know about is medical nutrition therapy. Medical nutrition therapy, we have discussed in detail on the nutrition module. Please go back and listen to that module, which is very, very important for us to know how we need to calculate the calories for this patient, because restriction of the calories is very, very important. At the same time, we have to ensure that the mother gets adequate nutrition, the fetus get adequate nutrition. So, when we plan for that, it has to be individualized. No one size fits all. So, don't give a blind chart paper saying that this is what the patient needs to take. So, each patient is different. Each patient has got a unique breakfast. They take a unique lunch and unique dinner. So, individualize for that particular patient what they need to take. So, when we are planning that, always we need to know what calories they are consuming and what calories that we need to target and what calories are we prescribing for that particular patient by restricting the other things which are not needed. So, the cornerstone of GDM management is medical nutrition therapy. That is very, very important. Any given patient, once we have diagnosed as the typical GDM that we are talking about, patients who are normal earlier, 24 to 28 weeks or 20 to 24 weeks, we are diagnosing them as GDM. And the patient whom they get resolved after pregnancy, the typical GDM that we are talking about. So, any patient for that matter, nutrition is very, very important that we need to individualize for them, as we said. So, some women with GDM will be able to manage their glucose level effectively with medical nutrition therapy alone. So, whomever comes, like except for the patient who are diagnosed type 2 or a type 1 in the first trimester, except for them like whom we need to aggressively start them with the insulin in the first trimester itself. So, except to those patients, the typical GDM as we had described earlier, so they have to be given the medical nutrition therapy as the first module even before starting them on insulin. So, 1 or 2 weeks, see for 1 week, put them on medical nutrition therapy, see how they are responding, and if the response is good, extend it for another 1 more week and see whether they are able to control whatever be the sugars. Let it be like 200 postprandial or 240 postprandial. Always cut down on the unnecessary calories that the patient is consuming, individualize the patient for the calorie intake and offer them a good physical activity module also. And with this, we will be able to see them very nicely responding to the medical nutrition therapy. So, it is very, very important for us to give a individual plan for them. Fulfill minimal requirements which are recommended for the patient. So, whatever like the nutritional requirements that the patient require, we have to fulfill it. Achieve glycemic goals without any weight loss or undue weight gain also. So, we should ensure that they don't lose weight also, at the same time they don't gain more weight also. And the most important thing that we need to know is, we have to avoid ketonemia or ketonuria from calorie restriction or starvation. So, when we talk about diet restriction, calorie restriction and all, make sure that the patient don't starve for a longer period of time, say intermittent fasting or the other forms of restriction of calories. They should not follow in this, because if they are fasting for a longer period of time, if they have the dinner at 7 o'clock and if they are going to take the next day breakfast, say around 8 o'clock or 9 o'clock, whereby they are restricting for more than 12 hours, always the patient might be prone for ketonemia or ketonuria. So, these ketones which are produced may unduly affect the fetus. So, we should make sure that the patient doesn't do all these things, and avoiding ketonuria is very, very important. So, what do we need to do with this patient? We have to just offer them a when they go to dinner, they can take a pre-dinner, pre-sleep snack sort of thing. So, that will ensure that they don't go for ketosis. So, things like that we should ensure. Frequent small meals are always important. So, that is important. So, whatever they consume, we have to ensure that they split and take, so that the nutrition is available throughout the day, both for the mother as well as for the fetus. At the same time, they are not getting prone for ketosis. So, this is the management goal that we need to follow. So, the ideal body weight we need to know. So, in these patients, the ideal body weight is 18 to 24 for the BMI. The recommended weight gain is 8 to 11. So the number that we need to remember is the ideal body weight for these patients is as per the BMI calculation, it is 18 to 24, and the recommended weight gain for this patient is 8 to 11 kgs. So if the patient is overweight, as you see over the chart, if they are overweight, obese or morbidly obese, we have to restrict the weight gain as given over here in this chart. If they are underweight, we have to ensure that they are gaining slightly higher also. So this is the thing that we need to follow. So based on this ideal body weight only, we are going to calculate the calorie requirement for that patient. So when a patient comes, once you know their BMI, what we need to, when we offer the calorie chart as per the nutritional module that we had discussed. So when they come in the first trimester, if their BMI is, as we have discussed over here, if their BMI is between 18 to 23 or 18 to 24, when their BMI is like this, we can give them 30 to 32 kilocalories. So always we should remember, it is based on the ideal body weight. If the patient, suppose if the patient comes, an obese patient comes with a BMI of this, so even then the calories should be based on the ideal body weight. It should not be based on the weight of the patient. So we should not say, let us presume that the patient's weight is about 90 kgs, and for an ideal BMI the patient needs to be only 65 kgs. So we have to calculate the calorie requirement only for this 65 kgs, not for this 90 kgs, which is very, very important. So in the first trimester, that the calories that we are going to recommend for the patient based on the ideal body weight is 30 to 32 kilocalories per kg. If it is in the second and third trimester, we give some increment for the baby. So 300 kilocalories we can add, or it could be 38 kilocalories based on the ideal body weight. So for the first trimester, remember the number is 30. For the second and third trimester, remember the magic number is around 35 or 38 kilocalories. So the other nutritions we all will be discussing in detail about in the nutrition session. But for our session, the numbers are 30 and 35.